Good morning, everyone. Myself, Dr. Ankita Gogoi, and I'm here to present a case report titled Intra-orbital Wooden Foreign Body Mimicking Lead Mass. The authors have no personal, financial, or institutional interest. Intra-orbital foreign bodies are a global injury and occur with a frequency of 1 in 6 orbital injuries. However, an intra-orbital wooden foreign body constitutes a relatively rare ocular trauma. The clinical outcome depends on the severity of the initial trauma, the location of the intra-orbital wooden foreign body. Visual loss typically occurs as a result of the initial injury and the complications. They carry the risk of damaging the orbital contents, intracranial extension due to conical shape of the orbit. They might also give rise to different types of complications such as granuloma, orbital cellulitis, orbital abscess, osteomyelitis, periosteitis, or chronic fistula. The diagnosis and management of intraorbital wooden foreign bodies are difficult as the history and external signs of injury are often scarce or absent. There may be a long delay between injury and the presentation, and the foreign bodies may be missed by the regular imaging modalities. So here's my case report. A 45-year-old female presented with a left lower lid swelling for the past 6 months, which was gradually increasing in size, and for the past month, it was also associated with pain, watering, discharge, and diminution of vision. Uncorrected visual acuity was 6.9 in the right eye and 6.24 in left eye. Ophthalmic examination of left eye revealed a tender circumscribed hard swelling in the left lower lid associated with conjunctival congestion and marked chemosis and restricted extraocular movement in lateral gaze. Her anterior chamber was quiet and pupils are reactive. Ophthalmic examination of the right eye was unremarkable. She gave a history of trauma to the left eye 1 year back by wooden broom. However, as she was asymptomatic, no treatment was taken then. There was no other relevant surgical, allergic, or medical history in the past. So this is the picture showing a circumscribed hard swelling in the left lower lid region. It is associated with conjunctival congestion and marked chemosis in the lateral half. The extraocular movement was restricted in the lateral gaze. The patient was evaluated with CECT orbit, and it revealed a linear hyperdense structure 2.3 centimeter in length and 3.7 millimeter in thickness in the left lateral rectus with surrounding inflammatory changes. Her CBC RBS were within normal limit. So this is the CT scan showing the wooden foreign body trapped in the left lateral rectus muscle. The patient was admitted and IV broad-spectrum antibiotics along with topical antibiotic eye drops were started. Systemic analgesics and anti-inflammatory drugs were also given. The foreign body was carefully removed under local anesthesia by a small subciliary incision. Culture swab of the wound was taken. The inflammation gradually subsided and the patient recovered well after the removal of foreign body. The patient was followed up for a period of 3 months, during which her vision improved to 6.6 and she regained full ocular motility. So a wooden foreign body inside the orbit or cranium may be difficult to diagnose, especially in cases of apparently minor trauma. When a patient presents with a history of ocular injury caused by organic materials such as wood, the possibility of retained intraorbital foreign body must be considered, particularly when there are signs of inflammation and limitations of extraocular movement. CT is currently the gold standard for detecting intraorbital wooden foreign body as it is cheaper, easily available, fast results, suitable in children. Wooden fragments not only pose a risk to adjacent structures from physical injury, but also associated with significant risk of infection. A timely exploratory surgery, removal of foreign body with heightened level of attention, post-operative antibiotic prophylaxis and follow-up essential in its management. So to conclude, high index of suspicion supported by a proactive history, clinical examination and good quality CT are essential for diagnosing an intraorbital wooden foreign body. Early management is essential to reduce ocular and adnexal morbidity. Early surgical exploration and foreign body extraction greatly influence the visual prognosis and the final outcome. These are my references. Thank you.
Thank you, Dr. Ankita. I think just one thing, did you rule out any fungal infection?
Sir, the culture swab was taken from the...
KOH?
Yes, sir.
KOH also?
GIMSA, GS, culture sensitivity and KOH, sir. But all came out to be negative, sir.
So she was not covered for antifungals?
Antifungals were not used, sir.
Okay, fine.
Thank you, sir.